Good afternoon. I should probably start by saying this, that about a month ago, when I was communicating by email with Alyssa about this talk, she asked me, what song do you want to walk up to? And I thought she was completely joking. So jokingly, I responded, whatever 007 song you want to pick. And so I'm now totally embarrassed, but that's besides the point. So the volume of surgical procedures, let me just see, how do I advance this thing? There you go. The volume of surgical procedures that are done in the ambulatory surgery centers have increased very rapidly over the past 2 decades. The RAND Corporation, in a 2012 American Journal of Surgery article, concluded that the cases that were done in ASCs were 37% shorter in length than the same case in a hospital setting. The total perioperative time was 39% shorter. The time in the operating room was 37% less, and the recovery itself was 35% shorter. These cases save Medicare about $2.3 billion annually, and the total system about $38 billion annually. As far as spine surgery goes, the frequency and the complexity of spine surgery that's performed in an ambulatory surgery center has also been steadily increasing. These things started with lumbar marker decompressions and then anterior cervical procedures, and then followed eventually with minimally invasive lumbar fusions. There's a positive data, though, on the safety and efficacy of most spinal procedures that are adapted to the outpatient setting. And as far as anterior lumbar procedures go, there's basically no data that I'm aware of on feasibility, safety, and effectiveness of anterior lumbar procedures, both ALIFs and disc replacements in an outpatient setting. So we performed a retrospective matched cohort study looking at 213 cases of consecutive adult patients who underwent elective standalone anterior lumbar cases in the 2016 to 2019 timeframe. These included ALIFs, ADRs, and hybrid procedures. And the patients were matched as far as age, sex, body mass index, and medical comorbidities, and we looked at length of stay, readmissions, reoperations, and complications within 90 days. And the complications that we assessed were the whole host of complications you would expect potentially happening after anterior lumbar surgery, which is neurological injury, potential durotomies, vascular injuries, bowel injuries, postoperative ileus, epidural or retroperitoneal hematomas, urinary tract infections or urinary retention, DVTs, PEs, surgical site infections, and medical issues. So as you can see, the two groups were all very similar in age, sex, BMI, and medical comorbidities. The majority of cases were single-level ALIFs or ADRs, and the postoperative length of stay was higher, as expected, for the inpatient cohort compared to the outpatients. And while there were no statistically significant differences in these groups as far as outcomes went, the inpatient cohort trended towards a higher rate of complications and postoperative ER visits and readmissions. So let's take a slightly deeper dive into the complications of these patients. So the inpatient cohort, there was 5 vascular injuries, 4 of them in 2-level cases, and all of them were repaired with a hemoclip or single figure-of-8 suture. And there's 1 retroperitoneal hematoma that was observed without intervention, and 1 reoperation, which technically is not a real reoperation. It was for a disc herniation at an adjacent segment for a patient with unrelenting lumbar radiculopathy. In the outpatient cohort, there was only 1 complication. That was a lower extremity DVT that was treated without sequela. As far as ER visits and readmissions go, in the inpatient cohort, there was 2 ER visits, 1 for a patient with leg numbness, who was then subsequently discharged, and 1 for a patient with concerns for leg swelling, where an ultrasound was done, DVT was ruled out, and the patient was also discharged. There were 2 readmissions, 1 for pneumonia and 1 for a retroperitoneal hematoma, which I mentioned earlier, and that patient was observed without intervention. In the outpatient cohort, there was 1 ER visit for a rash on leg and torso that was then found to be unrelated to the surgery, and that patient was discharged as well. So in summary, while there's no statistically significant differences in the complications or reoperations between the inpatient and the outpatient cohorts, we did find a lower readmission rates for outpatients compared to inpatients, and I think that this data supports the conclusion that anterior lumbar procedures, including 1 and 2 level ALIF and ADRs, can be performed safely in an outpatient setting. But then the question becomes, what are the ingredients for success in doing this in an outpatient setting? So this then starts with I think the most important thing is an appropriate patient selection by the surgeon preoperatively, and the appropriate expertise and efficiency of both the spine surgeon and the vascular access surgeon who can do these procedures safely, efficiently, and without much blood loss. It requires a detailed preoperative anesthesia survey and an expert anesthesia team in the surgery who can manage these patients correctly. Expertise and efficiency on the part of surgical techs and the rest of the surgery team, and postoperative nursing that's geared towards rapid recovery and same-day discharge to home. But even that's not enough. This also takes a laser-sharp focus, a well-designed system, including cell-saver support and other things that we need for backup, appropriate backups as far as transfer protocols and hospital availability for contingencies, and a sense of ownership of the process for everyone that's involved, that's all centered around the patient. It takes all of these factors, human, machine, and system, to come together as a team around the patient to do this right. Thank you.